stage.
So when I was asked to address the PA and NP role clarity issue, I thought this could really be a huge task. Fortunately, we were presented with the 3 questions which were shown earlier, so it gave me some focus and things to think about. So I'm going to try and stick to those and address those specifically and hopefully stay within my 15 minutes or so. In doing so, I've also addressed these to the best of my knowledge. So, you know, if I misspeak in any way, I invite Eric and Ruth to correct me if I speak incorrectly at all, but this is a good opportunity for education, and so hopefully I'll have it right, if not. So first off was the question about similarities and differences. I think we have a lot of similarities, so I broke it down into a few standard kind of ones. So first of all, we're both members of interprofessional healthcare teams, and we work together along with other disciplines to bring together well-rounded care for our patients. And really, we have vital roles in improving access to early care, reducing wait times. So in that sense, you know, we sort of all have the same goal. PAs and NPs, as far as I know, definitely for PAs, we can work in all areas of medicine, and my understanding is that NPs can as well. So that can be, you know, speaking from the PA role, I'm working in the emergency department, and even just within my graduating class, we had a diverse group. So a number of us were in the emerge, there's family medicine, internal medicine, orthopedic surgery, trauma, nephrology, so a vast array. And then as well, probably one of the largest similarities we have is really the basic functions and skills that we're providing to our patients, taking histories, physical exams, ordering and interpreting investigations like blood work and diagnostic imaging, and then implementing care plans and treatments for our patients. But where we start to differ is how that actually happens and how that care actually gets to our patients. So first off, one of the differences, nurse practitioners are nurses, right? Whereas physician assistants, we come from a wide variety of backgrounds. So as I mentioned earlier, I was previously a paramedic, but we have come from a wide, diverse group. And again, in my class, you know, we had behavioral therapists, social work, respiratory therapists, radiation therapists, and it goes on from there. We've even had nurses come through the program as well. So again, it's diverse. Then, as has already been mentioned, nurse practitioners are regulated and PAs are not. This, however, is sort of, as Eric had alluded to, this is kind of in flux at the moment. Last year, HPRAC, the Health Professions Regulatory Advisory Council, had asked CAPA, the Canadian Association of Physician Assistants, to formally apply for regulation. So I sat on the committee for CAPA that was involved in putting together that application. And the goal, you know, we all know that things don't necessarily happen in a timeline we want, but the goal is that that application was submitted in early January of this year. It is to be formally reviewed by fall of this year, and pending that HPRAC will say, yes, they want PAs to be regulated, the set goal for that to happen would be September of 2013. So we'll see. And then as well, another difference, NPs are autonomous providers, which has already clearly been laid out for us here, and PAs are not. PAs are delegated to do their acts by the physicians, the supervising physicians that they're working with. So what that boils down to is that NPs can act as the sole provider of care to a patient. If that care required falls within the scope of practice of the NP, they could be the sole provider. PAs, on the other hand, always have a physician involved in the care of their patients. So they may make clinical decisions and treat patients based on the directives that they have in place and the relationship that they have with their physician, but the physician is always involved in some aspect. So that plays out a little differently depending on where you are. So for me in the emergency department, my physicians will always see the patients that I see at some point. But when that happens and how it happens depends on a variety of things. For one, it may be acuity of the patient, it may be comfort level, it may be You know, are there current directives in place that allow me to do everything that needs to be done? But for somebody so I guess I should give an example of that. So suturing is something that's pretty straightforward. You know, see a laceration, assess the laceration, do what's necessary to correct the laceration, and then my physician may just come in at the end and say, hello, check it out, and the patient can leave. However, somebody who is more acute, more unstable, the physician would be involved at an earlier point. But if you take maybe the family med example, you could have PAs seeing patients. They may have a list of patients that they're going to see all day, and they may do what's needed for each and every one of those patients. At the end of the day, review that list with the physician and say, I saw Mrs. Smith today, maybe for her diabetic follow-up, and I did X, Y, and Z for her care. The physician is always involved. They know what was done, and they know what's going on with that patient's care. Versus the NPs, of course, which are autonomous providers and can do that care on their own without referring to a physician. We call this, sometimes the term used for that, for PAs is called negotiated autonomy. And that's simply because medical directives are in place which allow PAs to make decisions and to provide care under the relationship that they have with the physicians. And then the other big difference, of course, again, already mentioned, is the nurse practitioners have a defined scope of practice, whereas PAs do not. So again, nurse practitioners can provide their autonomous care without the involvement of a physician within their scope of practice. But the PA scope is not quite, well, it doesn't really exist. It is determined by a number of factors, 3 major ones. The first one is education and training. So PAs undergo a PA education program like the one here at McMaster. And involved in that is an expected standard of education. You go through certain clinical rotations, you learn certain aspects of medicine. And that all fulfills the criteria that is set out by the CAPA, Canadian Association of Physician Assistants, their National Occupational Competency Profile. In addition to that, once a PA is hired, employers tend to offer, you know, depending where you are, there's a level of education that comes automatically. So you train for a period of time specific to your location and the discipline that you're in. And then, of course, as all healthcare providers have, there's always CME opportunities as well. The second aspect that falls into scope is the regulations that pertain to the PA's practice. So we've said that PAs aren't currently regulated. That is in the process. But one aspect of this that would be incorporated is the Delegation of Control Acts, like Dr. Cunnington had talked about. There's policies in place for what acts can be delegated and how. And then the third major aspect of how a scope of a PA is determined is through the delegatory relationship between the PA and the physician. And this works in a couple different ways. So first of all, it's determined by the physician that you're working with. And this is because a physician cannot delegate an act to a PA that is not within their scope. And second, it's about what acts are they going to delegate to the PA. And that's determined based on the physician assessing the competencies, the education, and the skills of the PA that they're working with. So you could have a PA, you could have 2 PAs working in the same environment and actually working in different capacities. If they bring different competencies and skills to that job, they may actually work differently in that same environment. So what this boils down to then is that the nurse practitioners have their scope of practice, which is set out for them by the college, and then the PAs is determined by a variety of factors depending on where they're working and who they're working with. So the second question was about my interactions with nurse practitioners and how they've affected my delivery of care. I actually don't have a lot of personal experience working directly with NPs. I just have a few examples. The first would be in my department. We do have a couple students, or nurses who are students in the NP program, and so I've talked to them. We've also had one in particular who graduated from the NP program here at MAC. And so we've had lots of interesting conversations. They were curious, especially in Oakville where I work, they hired 2 PAs at the same time, so they were curious, to know more about us when we first started. But it's always been very welcoming and a very good and a very positive relationship that we've had. Within our hospital, there's another NP as well, just outside of our department. And although I don't get to interact with her very much, again, this is very positive. She's been working in her department for a very long time. She's extremely well respected within the hospital. her experience, her knowledge. So she's a fantastic resource. So the few times that I have interacted with her, I actually, it's been very positive. And then just to speak outside of my own personal experience for a moment, a number of the people that I went to school with, they actually did a rotation, a core emergency rotation, in an emerge department that had an NP working there. This department was quite familiar with PAs because they had spent a number of years actually training military PAs, so they were quite comfortable with the role. And every single one of my fellow classmates who returned from this rotation spoke about the impact that this nurse practitioner had on their education. She was so positive and welcoming to the students. She would take them aside, she would teach them skills, they would have long conversations, and it was just very, very encouraging for them. So that was actually really nice. They actually learned quite a bit from the nurse practitioner, sometimes in certain shifts more from the nurse practitioner than they were learning from the doctor. So it was a positive experience for all of them. And then, so how does this affect my delivery of healthcare? Well, unfortunately, since I haven't had a lot of experience working directly with nurse practitioners, I can't say it's necessarily affected my care directly, but I was thinking about, so what if there was a nurse practitioner in my department, how would that differ? And I can't even begin to speculate how it might be different, but I think it would actually be very interesting, and I know that it works in many places. So, you know, like I said, I don't want to speculate, but I can imagine that it would be really, really interesting, and I know that it works, and that we can make it work, so hopefully that will be something that will happen in the future. And then the last question was about, should further steps be taken to delineate the responsibilities of each of these roles? And when I thought about this, I really thought, I wasn't sure if I believed that it should. Why are we spending so much time on this? I'm not sure. Maybe I'm approaching it from the wrong perspective, but what I feel like is, what would be the benefit and the purpose of spending all of this time and energy delineating so much when, what was it going to change? What would be the purpose? There's plenty of patients for us all to see. And they're really happy to, patients are really just happy to be getting timely, effective, appropriate care. We can work together cohesively and effectively. It's been shown, it's been proven. And in the end, I think the patients are happy with everyone. So I think that the care is really what matters. And that's sort of the theme that we've all talked about. So that's where I'd like to end it off. Thank you.